Hello, this PowerPoint presentation will be on drug therapy in the geriatric patient. In the older adult, they have a higher prescription use than any other population. They also experience more adverse drug reactions and drug-to-drug reactions than the younger patient. The older adult has altered pharmacokinetics, which makes them more sensitive to the drugs with greater variation. They have multiple and more severe illnesses. They have multiple drug therapies, polypharmacy. Sometimes it's excessive. That's where it's important for you to have an accurate list of what your patient's taking. There's also issues with poor adherence, issues with, so it's important that you look at the individual patient, that you monitor your patients for their desired and adverse responses, and that making sure that they're able to adhere to the regimen. And sometimes it's just something as simple as that their copay is too high, or that they have a copay and that they don't have the finances for that copay. And so patients will forego taking a med, or they'll take it less often than they are supposed to. If the med's twice a day or 3 times a day, they're taking it once a day, which of course is not giving them the effectiveness that they need to have the medication. And always keep in mind the goals of treatment and convey those goals to your patient, which is to reduce their symptoms and improve their quality of life. As far as pharmacokinetics and absorption are concerned, um, the uh, overall absorption of medications is not a problem. Uh, the amount of the oral dose that is absorbed is not a problem. The rate of absorption may slow, and that's due to delayed gastric emptying, um, and reduced blood flow. That in regards to distribution, um, there is an increased percentage of body fat in the older adult, and this storage can be a problem for lipid soluble drugs, so that they will retain more of that medication in storage, which could lead to toxicity. Um, Therefore, there's a decreased percentage of lean body mass. There's also a decrease in the total body water in the body, um, where their concentrations can be increased, again leading to the potential for toxicity. And there's also a reduced concentration of serum albumin, um, and this can be caused many times because of the malnourishment of the patient. And because of this decreased binding, um, there are increased levels of free drug, which again can lead to toxicity. Their hepatic metabolism does decrease and decline with age, because of decreased blood flow, reduced liver mass, and activity of the enzymes. Therefore, the half-lives of some drugs may increase, and the responses may be prolonged, and there could be potential for, again, for toxicity from the drugs. Um, and because many drugs undergo uh, extensive first pass effect, which means most of it's metabolized in the liver, their effects can be enhanced. So also there with excretion, um, renal function also starts to decline, and that actually starts to decline in early adulthood. And drug accumulation can occur because of the reduced renal excretion. So for both of these, renal and hepatic, it's very important to know the status of both of those organs by getting baseline labs when the patient started on a medication, and to get labs periodically throughout the course of treatment. So just what I said, that you want to check for renal function, and the function from a renal perspective that's most important is your creatinine clearance. And when you start to prescribe, or if you notice now, many meds will talk about their creatinine clearance, and depending on what that is, how to adjust the dosage of the medication. Pharmacodynamic changes in the older adult. Um, there are alterations in the receptor properties. So drugs with more intense effects in older adults, like warfarin and certain central nervous system depressants. So you have to be careful with the dosing of those medications, because you don't, with the central nervous system depressants, you don't want the patients getting dizzy, or they're drowsy and they are falling, which can be very serious. Beta blockers can be less effective, even at the same concentrations, because they have reduced number of beta receptors, so that those meds doses maybe have to be altered, or you may consider going to a different medication if needed. The adverse drug reactions, they're 7 times more likely in the elderly. They account for 16% of hospital admissions, because many of those are due to falls. 50% of all medication-related deaths in the elderly are from adverse drug reactions. The majority are dose-related rather than idiosyncratic. And the symptoms in older adults are often non-specific. So they may just be the dizziness, cognitive impairment. So it's always important when you're to know that distinction of between delirium and dementia in your older patient. Um, Delirium comes on suddenly, so the patient may be fine in the morning, and by the next day or that evening, they are very confused, and that is not to be, um, on your part, confused with, sundowners, which will occur every day normally. This is something that's very new, very sudden, with a very sudden onset, where your dementia has a very gradual onset. Okay. What are some things that predispose to adverse reactions? The drug accumulation from the decreased renal function, from the polypharmacy, having so many medications. And one thing I have to say with polypharmacy is I make sure my patients at least periodically bring in all of their meds. I don't care if I prescribe them or not, so that I can see what they're taking from all their providers. I have found patients on many occasions that are taking multiple forms of the same med. They don't know trade name and generic names. I had one patient that was taking um, had 3 different bottles of Lasix from 3 different doctors, because of course when they went to one doctor over the other, they don't remember names. They're all white, the little white pill. And so they had one bottle was Lasix, one bottle was furosemide, and so they don't know that those are the same medication. And patients oftentimes want to be the good patient, and so they just go along with whatever you're going to do that visit. They don't necessarily speak up, or want to contradict by saying, I'm already taking that medication from someone else. There's a greater severity of illness. They have multiple pathologies. There's a greater use of drugs that have a low therapeutic index, like DIG. Um, there's increased individual variation. There's inadequate supervision of long-term therapy, especially if the patient's still living in their own home, um, or even if they are living with family members, but no one's really paying attention to what they're taking. And then there's poor patient adherence for multiple reasons. So how can you help reduce adverse reactions? You can obtain a thorough drug history, and like I said, including the over-the-counter meds. And like I said, really encourage the patient to bring in all their medication so that you can at least in the beginning of your uh, treatment, or if they're new to you as a patient, so you can see everything that they're on. Um, you want to consider those pharmacokinetic and pharmacodynamic changes. You want to monitor their responses and make sure you're getting those blood levels. So make sure that you're not missing that opportunity to get labs when the patient can come into the office. You want to use the simplest regime possible. So if the patient comes in on multiple meds, especially for one illness, see how you can uh, be more efficient in their drug therapy. You want to monitor for drug reactions. So every visit you want to ask about symptoms that could be common for those drugs. Um, you want to periodically review the need for continued drug use and not just keep a patient on a med because it's always been on their um, list of medications. You want to encourage the patient to dispose of old medications, whether they can bring them to you or you can direct them to the pharmacies. Many pharmacies are able to take the medications from the patients. And you want to take steps to promote adherence and avoid drug uh, that are on the Beers list. So you need to be familiar with that Beers list. You'll find that in your text. And also, like I said earlier, you want to make sure that you don't miss that opportunity to find out that the patient has the funds or the insurance coverage to get meds. And if they don't, you may have to change the drugs based on that, or there might be drug programs that are out there from the drug companies to help pay for the medications for the patient. How can you help promote adherence with unintentional non-adherence? Simplify the regime so that they don't have so many to remember. Make sure that the directions are clear and that they're verbal and written. Make sure they have appropriate dosage forms that are best. If they're having trouble swallowing now, that maybe a liquid form would be better for them um, to use. Um, make sure everything's clearly labeled and they have the easy to open containers. If they do not have young children in the home or visiting frequently, they don't need the safety caps, which can be very difficult for a senior to open. Make sure they develop some way to have a daily reminder, whether they can have it on their phone, if they have an Alexa in their house that can remind them to take their meds. See that they have a support system, somebody that checks on them, or that they may need to consider residing in a residence where they can be looked after. And what do we do about intentional non-adherence? Most cases of non-adherence are intentional. Reasons include the high cost of drugs. So like I said, you may need to switch to a more reasonably cost med, even though you might want to use the newest med that's out there because you believe it might be more effective, but if the patient can't afford it, it's useless. Look at drug assistance programs for the patient. Uh, Monitor for those side effects because if they're having side effects, they're going to stop taking the meds and they may just not tell you because, again, they want to be the good patient. Um, and the patient's beliefs that the drugs are unnecessary or that doses are too high or their family's telling them that they don't need medications. So just make sure you're taking a minute to talk to your patient and find these things out so that you can help them be more adherent and have a better uh, drug adherence and quality of life. So the first question is you have an 82-year-old before administration medication, what labs would be um, best for the renal function. So of course the answer here would be D. Said earlier that the best indicator would be the creatinine clearance when you need to consider that the renal function in prescribing or dosing of a drug. A next question, you have an 82-year-old with um, an over-the-counter med that's considered safe. When should you intervene? The answer here would be A. The chlorotrimazole for the cold um, has anticholinergic effects, which can be blurred vision, urinary retention. So because of that, you would want to advise the patient not to take those. The other meds would be acceptable. Of course, the Benadryl can make them drowsy, but so you would want to avoid that because of that, because you don't want any falls. And the last question, they frequently forget to take their meds. It has been prescribed 3 times a day. What would you do? And the best answer is C. You are the prescriber, so you wouldn't call the prescriber, but you would you could try to get that changed to a sustained release form of the drug, so they could take it just once a day. Of course, again, don't forget to check on the cost of changing, because the sustained release is probably going to cost more, so that won't help if the patient can't afford to get it. So you have to look at that as well. You may just need to change to another med that can be taken maybe at least just twice a day, if not once a day, and also will be within the cost means of the patient. And that is it for this lecture. Thank you very much.